Good afternoon, everyone, and welcome to the third in our Better Together series of virtual events. Today, we will be focusing on Beyond Recovery, the 6 commitments of revenue resilience for health systems as they grapple with the situation in the market and look to move forward in the months and years to come. Joining us today is a panel of industry experts: Sam Badia, a physician executive from Salesforce; Paul Griffiths, a General Manager, Digital Health Solutions, joining us from Perficient; and finally, Tom Keesaw, a Senior Partner, joining us from the Chartis Group. Just a friendly reminder that this session will be recorded, and please make use of the chat window on your right to ask questions, as we will be having a Q&A session at the very end of this presentation. One quick note from our legal team, a reminder for everybody that they should make all their buying decisions based on generally available products from Salesforce. With that, let me hand it off to Dr. Sam Badia, who will formally kick off our presentation. Sam, over to you.
Thanks, Asma. So the question is, if you could turn back time before COVID, what would you do differently? Today, we're going to put some thought leadership into this question, and more so talk about what we could have done or what could we have committed to be in order to be more resilient during this time of a health crisis. Next slide. I'm going to be presenting with my colleagues today, and just a little bit about myself. I'm Dr. Sam Badia, as Asma mentioned, a Salesforce physician executive. I've been a clinical informaticist for over a decade, working in venture capital and the EHR world. I've always focused on innovation throughout my career, and innovation with a big impact, low cost, and impactful change to healthcare organizations. Today, I'll be presenting with my partners, with our aligned partners at Salesforce from Perficient and Chartis Group. And we're going to be talking again about the 6 commitments of revenue resilience.
My name is Paul Griffiths. I'm the General Manager, Digital Health Solutions at Perficient. I've spent the last almost 20 years thinking about the healthcare consumer and their journeys and how to make that journey less stressful and more efficient. Today, I'm really excited to be here. Thanks for having us. I'm here representing the kind of consumer engagement view. And as we seek to answer these questions about revenue resilience, we're grounded in understanding of how consumer behavior is changing and how healthcare organizations might need to adapt. And I'm likewise pleased to be joined by my colleague, Tom Keesaw.
Thanks, Paul. Tom Keesaw. I'm a senior partner with the Chartis Group, and I lead our Chartis Digital Business Unit and work with health systems across the country on digital transformation initiatives, everywhere ranging from enterprise digital strategies through supporting the actual deployment of digital transformations, things like hospital at home, digital first primary care, or consumer outreach strategies. Great to be here. I look forward to talking to everyone.
So this is the team that we assembled. I think if you go to the next slide, and really with an understanding of looking at a physician view, operational view, and kind of a consumer view. Each of us will kind of introduce our organizations a little bit, just so you have context for who we are and why it's worth listening to us. So I'll do kind of 30 seconds. Perficient may not be familiar to you. We've been a Salesforce partner for 13 years. We have numerous locations across the United States and indeed the globe. And our clients are typically integrated healthcare organizations from payers to providers. And my team especially focuses on providers, clients like Ochsner Health in Louisiana, or Henry Ford Health System outside of Detroit, just to name 2. And I'm, as I mentioned, really talking from the perspective of that consumer piece. As healthcare moves to really understand what consumer journeys look like, what I'm really interested in answering, and my angle in answering this question is about that last interaction. How do we create a compelling experience for patients in a world where so much is changing? And certainly there's a lot of great stories that my colleagues at Perficient have done over the last, since 1997, really, last 20 plus years in the space. So with that, what we'd like to do is to walk you through a little bit more of how we ended up here. If you go to the next slide. This question that brought the three of us together was centered on this. If we could go back, if we could turn back time, what decisions would be made differently? What do we know now that we would apply? And we started these conversations a few months ago, before it was maybe now clear that medically speaking, COVID's going to be with us for a while. And this feels like a very timely conversation to have, because we've attempted to answer this question by engaging with the healthcare organizations who know and trust us to try to find some bright spots. So really, our goal today is to present some positive news in the midst of this, which I know can be a challenge, and maybe some encouragement of what's actually working out there. And I think that's why the three of us have assembled together, giving you kind of three different points of view, but really with an eye towards how do we create healthy and sustainable healthcare systems. If you go to the next slide, what we've done as we've tried to answer this question is go out and talk to numerous health system executives. And now that we've had a few weeks or in some cases months of understanding what challenges we face, we have the benefit of understanding what would have helped us, right? We have a little bit of hindsight. And what we've learned as we've asked this question through a number of executives is we've identified some things that, boy, executives wish they had in place before COVID. And that led us to try to put those different learnings together into something that felt like a directional, direction for organizations to really head. And what we emerged with were 6 commitments. And those 6 commitments are really about how organizations can ensure their survival in this new reality. And I know that's an awful lot. That's a pretty big offer to make, that we've tried to boil down what's working out there in the market into 6 things. But they're significant. And the reason they're called commitments is because it is going to take organizational commitment to get there. That we don't see any, unfortunately, easy fixes. But what we do see is an opportunity for organizations to take a challenge and turn it into some kind of long-term advantage for them and for the patients that they serve. Part of what kicked us off, and you'll hear from our colleague Tom in a few minutes, the Chartis Group did research on kind of consumer likelihood to seek care, and part of that research they produced this analysis, which was stunning to me, that hospitals are actually facing a 10 to 30% loss of volumes. And if you think about that amount of change in a patient market, it's certainly going to drive up competition, but I think it's also exposed the fragility of some current operating models. And this image on the right, which kind of segments out patients into likeliness to seek care or likeliness to return, it felt like the first few weeks of COVID, everyone was really focusing on that A group, the high acuity, the group who was waiting to come back and receive care. And what we realized, though, beyond that is there's a group that's hesitant, who is going to need to really understand protocols and cleanliness. And then there's a group who's just reticent, who's actually going to delay care. We're seeing some of this in the data, particularly for heart disease. People are delaying care to the detriment of their health. But there's also a group that's just going to exit. They're going to not seek care, either for insurance reasons or because they're trying to deal with the situation and cope with it a different way, or for financial reasons. And I think, unfortunately, this is just the start. So we put together a blog series. If some of you have read it, thank you. We've been publishing kind of weekly blogs on these commitments. Part of that will come into a white paper, which we're hopefully going to get some of your feedback on. And then we put together this digital presentation really to explore what could be an uncomfortable reality, because we recognize the hospitals are going to have to adapt as they begin to run out of patients who are simply just waiting to receive care. And so I think what we've realized is that the strategy has to change. If you go to the next slide, as we started asking this question, what we received back a few weeks ago was, no, we've got recovery down. We're going to call people. We're going to make it happen. We're going to pull together, and that was successful in the short term for a lot of organizations, but it's also not a strategy. And I think even a few weeks ago, it felt like, if we can just get back to where we were, we'll be okay. And I think what has emerged now is there is no more status quo. So if we understand that this need to be able to open and close and communicate with patients about care, where care is going to be delivered and how, that new reality is going to be with us for the rest of 2020 and beyond. It doesn't seem like that COVID, for example, is going to be fully eradicated at a specific time and a date anymore. It seems like it's going to be a much more complicated and nuanced public health issue. I think the second part of that, though, is that this is really forcing operational transformation. And so recovery was a good first goal, but now knowing that the situation is going to be fairly fluid for the next few months, we need to aspire to something higher. And I think some of the bright spots that we've seen is organizations have made pilots, radically successful. They have done incredible things in terms of virtual care delivery. So processes and systems that would have taken years before got done in months, in some cases weeks. So I think we all come to this as optimists and believing that if healthcare organizations want to achieve these things, they can. But now what we're seeing is that the goal is not to get back to where we once were. That organizations now are going to need to make these commitments to adapt in the face of uncertainty. That just today, I don't think it's very clear how and where and in every specific market the right course of action is clear to everyone. So what is clear, though, is that there are some significant commitments that organizations can make that will ensure that despite the uncertainty that comes to face them, they will be able to prevail. And so we've kind of put these thoughts together and we've adapted our approach. And so now we're calling this approach revenue resilience, which was a way to say that, recovery and getting back to where we were is no longer quite feasible. Now what we need to do is build systems of care and systems of care delivery that can continually adapt from here going forward. And that's the spirit of which that we're presenting these 6 commitments. If you go to the next slide, what we've done is we've boiled these ideas down to 6 commitments. The 3 of us will go around and kind of share each of the commitments just so you can you can hear our different perspectives. And what we'll do is we'll talk about the commitments and then maybe give you some examples of what you could do. And then our hope is that this is a way to open a dialogue. So at the end, we have some ways that we are hoping to continue this conversation. That said, these commitments are also everything that we've been able to observe that has been working, boiled down into some concrete and actionable directions. But they're not goals, right? That we recognize that things will continue to evolve and change. And so the idea of them being commitments is there ways for organizations to get in strategic alignment. And by getting in strategic alignment, we feel that organizations will be better empowered to adapt regardless of what specific instances they might face. So for example, this first commitment is about establishing the capability and expectations for one-to-one patient communications with demonstrated clinical intelligence. And the emphasis here is both on the capability, so you can deliver one-to-one patient communications, and the expectation that you've kind of trained your audience that they can rely on it. And what's going to make that reliable is this demonstrated clinical intelligence. And organizations who are committed to this are going to continually do better in the face of all these adaptations we're talking about. So if you go to the next slide, for each of these commitments, we want to kind of give you a little bit of vision behind it, and then, again, show you some examples. So this first commitment about this kind of one-to-one patient communications, what we see is certainly, again, through the rest of the year, hospitals are going to be struggling with timely, effective, and meaningful communication. And my purview, obviously, is thinking about that patient experience, but we acknowledge it extends to employees and donors and anyone really who a healthcare system is going to need to communicate with. And if you think about that expectations being set on scale, that healthcare organizations for the last few months have been the focus of a lot of interest and need for help. So patients who are clamoring to get timely information about how do I get a COVID test, or where do I go, or how do I receive care, to employees trying to figure out, is it safe, where should they go, to donors in the larger community trying to figure out how to help and participate. And it's been a great season, at least for healthcare, because we see a lot of respect and a lot of admiration for what healthcare workers are doing to deliver that care. The challenge, obviously, is now as we move into something that feels like a new normal, we need to make sure that we don't mismatch expectations, because the worst thing that we can do is create some negative goodwill now that we've kind of really shown up for our communities and deliver this incredible amount of care. I think this communication piece had largely been deferred to electronic medical records, but I think the acknowledgement that we're just making is they seem to have fallen short of the vision to deliver that one-to-one communication. That what we're talking about is not you've received another test and lab result. And what we're talking about is communication that has demonstrated clinical intelligence that's going to help me kind of better self-motivate and take the action that you need me to take. And if you think about right now, the complexity of patients and locations and services and what's open and what's closed, that need for one-on-one communication has never been more pronounced. So organizations who are really getting behind this commitment are going to satisfy these needs today, but they're also going to be well situated to satisfy needs in the future. And so our challenge here of what you can commit to as a first step is a pilot to raise expectations with patients, employees, and donors. And if you go to the next slide, sometimes people hear pilot and feel like it needs to be something that is, rigorous and thorough. If anything, we've been able to help organizations really think about how to do a short and focused pilot by understanding the organizational goals, the audience, what the civic journey is, what we need to say to the audience, and then making sure you have the tactics and resources to deliver on that. And what we're suggesting right now is it's more important to get a pilot and launch something to get the results so you can start to build and manage those expectations. So this commitment is certainly about taking action. That's kind of the first commitment. I'm going to pass it to my colleague, Tom, who will talk you through the second commitment, and I'll be back for the fourth.
I'll just do a really quick overview, similar to Paul. For those of you that don't know Chartis, we're the Chartis Group. We're a management consulting firm, an analytics firm that serves exclusively the provider and the healthcare delivery industry. About 450 people, and work with a wide array of leading health systems across the country. And we do consulting across all the common areas you'd expect, but one of our areas that you'll see reference here is Chartis Digital, which I lead, and it really aligns with a lot of the areas you're going to hear all of us talking about today. And again, we thought it made sense for us to share our collective perspectives on some of these topics. So the second commitment is one that we've seen and believe strongly has really been amplified by COVID, but expanding access to all clinical specialties virtually and deploying a clinical operating model that seamlessly provides both virtual and physical care as needed and demanded. And this is really important to think about in the context of what's happened with COVID. And the analogy I've used with a lot of clients is pre-COVID, we were really in kind of the virtual care starting blocks. And we'll see this with some of the data that's on the next slide. But the key point is less than 1% of all visits were done virtually prior to COVID. With COVID, we saw that number explode, and it was almost like launching out of the starting blocks, and we had to shut down physical and get into virtual. And we saw this first hurdle, and every health system that we work with was able to overcome it, figure out the problems rapidly within days in a lot of cases, and clear that first hurdle, which is let's flip from physical to virtual. The challenge we've created is that now as both are coming online, the next thing we have in front of us isn't another hurdle, it's a pole vault. and it has a totally different approach to be successful. And if we try to use what we learned and what a lot of providers have figured out in this transition, it won't work. And so just as we look at this commitment, it's here. Virtual care exploded, and we all know this and we experience it. The data just makes it even more clear. Nationally, there was a 3,300% increase in virtual care visits over a 4-week period. And then at their peak, they were actually the majority of all physician visits were delivered virtually in the first week of April. And now while that utilization has come back down, it's still dramatically higher than it was in the past. And again, it's as we're seeing some of the overall physical care start to come back online, we're seeing the denominator increase, but the numerator of the virtual visits has not dropped off as some people thought it might. And so for health systems, the challenge really becomes how do you efficiently and effectively provide both of those things? Because you're going to have to be able to manage your operating model and your clinician model without just flipping back to all in person. And so the commitment that we lay out here that we believe is that organizations have to begin this organizational transformation to develop a model that allows the coexistence of virtual and physical care. And with very few exceptions, this is not something that anybody had prior to COVID. It is a fundamentally different commitment, and it's a journey that will not be done with the snap of a finger. And I alluded to this data, but this is some data that we published in partnership with Cathera Labs, which is a claims clearinghouse that looks at several 100 million claims throughout the year and looks at them by week, and it breaks down by specialty, but tells the story pretty clearly. From the second week of March to the first week of April, the number exploded. But what we're seeing now as we continue to track this weekly is that the shift is starting to level out. And so it's not going to go away. And so if organizations don't have a mechanism to think about how they're going to do this in a more scalable way, it's going to continue to be a thorn in the side, and the experience for the consumer will suffer. And so we really believe there's 5 key dimensions on the next slide that are really imperative for health systems to think about as they approach this. And it's, like I said, 5 pieces. The care team dimension, and this is not just having the exact same physical care model to deliver virtual care. And the paradox here is for health systems, the ability to differentiate from the pure virtual players is our physical platforms. But at the same time, if we just try to digitize the physical platform, we're creating a structural model that just won't work with the care access and care delivery. The second one is the business model, right? And so how are we actually going to structure ourselves to support this new virtual and physical model, to support the clinicians, to support patients who are going to have different needs as they approach the health system through these new channels, and making sure that we're getting to a level of operational scale that doesn't just have this become more cost. The consumer engagement dimension is making sure we educate patients on these options, not just leaving it to patients to figure it out and be a willing guinea pig, but to actually communicate to them, this is available. This is a better option, we believe, for you. It'll protect you, it'll keep you safe. And by the way, it gives you new options and new timing availability to get in to see your doctor that maybe you didn't have before. The economic model may seem simple, but with how virtual care reimbursements are kind of playing out across the country, with some states having payment parity, others not, the managed care companies taking different tactics to how they reimburse for virtual care in the context of video versus telephonic versus e-message, figuring out what that new revenue model looks like and the associated cost structure, again, back to the care team that isn't the same old just physician-centric care model, is really important, and it has to be actively managed. And then the last piece, the technology, which in a lot of ways is the easiest one, but in the COVID reality, we've just seen things get thrown out there. And so how do you synthesize and really streamline your experience for the consumer to make it seamless and engaging and not maddeningly frustrating? And then across all these, how do you structure the capabilities to actively manage the transition? If you just assume it's going to happen, and we've had clients say this, well, we're leaving it to the doctors can't solve any of the 4 of these that aren't the care team. They can't solve the economic model or the support structure or the consumer engagement or the technology. So it is really incumbent on health systems to take this holistic view and begin this process if they're going to be able to compete with the evolving competitive landscape. Tim?
Thanks, Tom. As we face this unprecedented crisis of COVID-19, it's more important than ever to lead with values, just as Salesforce has for the last 21 years. And those values start with trust. You're only as good as your word. And we know our customers depend on us and our products to keep them in business, especially during these challenging times. And customer success. So if you're successful, then we're successful. Innovation, we believe that business is the greatest platform for change, period. And then lastly, equality. I'm proud to be part of a company that's made equality a company-wide initiative. Next slide. So the third commitment is to develop clinical operating protocols that clearly segment COVID and non-COVID patients to distinct sites of care. And so, next slide, what does this mean? I think this means a commitment to a digital engagement platform. And so what is a digital engagement platform? It's a platform that helps healthcare organizations connect with their patients and their members in a whole new way. So what does that mean? It means that right now, as my colleagues have mentioned, healthcare is so dynamic, and an organization needs to be able to pivot dynamically. We're seeing this dynamicy unfold almost on an hour-by-hour basis. Students are going back to school. I mean, in Georgia right now, 1 week into school, 260 students and teachers are going to be quarantined for 2 weeks after a positive case, 1 week into school. So the question is, how are we going to track each one of these patients on their journey? Because this is a journey. This isn't just a transactional care model. We have multiple school systems. We have multiple grades, demographics, and socioeconomics. It becomes further and further more complex. And we need, therefore, a more personalized encounter with each of these patients, yet we need to be completely digital. Next slide. So that kind of moves into Envision Healthcare, one of our clients, and what they wanted to do. They wanted to remain connected with their patients, but they wanted an empathetic experience, all while being contactless. And then simultaneously, they wanted to advance their business interests and remain profitable, which is quite reasonable and difficult right now during these times. So essentially, stay afloat while remaining contactless. And I think this vision is something that we can all get behind, especially in today's environment. You know, how do we react and how do we stay afloat? And a big portion of this is taking a deeper look into the areas of investment. And this has significantly changed during COVID. It's shown us that retail, restaurant, and healthcare all have the same point of view. And if I can get engaged digitally, I prefer that route. And so Envision was able to ramp up 1,000 physicians for ER telehealth visits, which is really impressive, especially with the fact that they were able to virtually triage 50,000 patients in a matter of a couple months. This aligned with what the patients and the docs and the nursing staff at Envision all wanted, which is the core of the consumer experience. Paul?
Thanks, Sam. The fourth commitment is to define each patient's next steps and actively support their journey by coordinating clinical reminders to close any gaps in care. So as we've talked about it, and go to the next slide, the complexity of having so many people needing to understand so much about themselves and take charge of their healthcare starts to create some interesting dynamics. So just as Tom was talking about the virtual care success, which I even wrote down that 20% of visits now are virtual visits. That's amazing. I think if you told me that last year, I would have said you were joking. But this virtual care success now actually complicates the market dynamics. So it's common to think about healthcare delivery as a pretty local competition. But if you've seen both the pressures on the health plan side to provide alternatives, as well as kind of the self-pay options, there's a number of different types of experiences that consumers now have. It's not just, oh, I tried something and it didn't work. There's been this radical shift towards virtual care with an understanding that brings along different competition. In fact, some research from Salesforce looked at attitudes, and particularly at Gen Xers, who I like to remind everyone is now that 35 to 50-year-old decision maker for the home and elder care parents. Those are Gen Xers. A little more than a third of them, and 40% of millennials think that they're going to get better care from providers if they do their own research. So this idea that, consumers are now making decisions about how they are seen and where they're seen, and they're much more self-generated and self-directed in their care, means that managing that care at scale is pretty different. So it might have been traditionally reliable that if you had a patient or a patient had an experience with you, you were going to get kind of all their downstream revenue and all of their future care. But now that patients have the opportunity to participate in these different modes of care, we as healthcare systems need to be able to help those patients take actions that are clinically directed and self-motivated. And so what do we mean by that? What we mean by that is that patients are going to want to feel like they're in more control, and they're going to take action. And the best things that we can do is support their journeys by understanding what that next best action is. And having that next best action is certainly heavily informed by clinical realities. And so if you think about what we wish we had before COVID hit, obviously every healthcare system in the United States would love to be able to have a way to not only communicate one-to-one with patients, as previously committed to, but also make sure that patients are following through on their journeys. And in case they start to fall out, or in case they start to make decisions which are not helpful to them or helpful to progressing their journey, that we're able to kind of come in and support them. And especially when it comes to managing ongoing gaps in care, if you look at the disruption of care that has occasioned just because of COVID, now we have a number of patients who are out there who are kind of off their journeys and off their plans. And so this idea that we can't just wait for the people to show up and the patients who were deferred to come back, what we need to do is really support the journeys of those individuals who are concerned or those individuals who are reluctant. And so managing care at scale is actually taking that into consideration. And that requires a really consumer-centric journey. And so the commitment here is for you to commit to a strategy that really serves patients equally, regardless of how they want to connect. Meaning these different modes of care, having the ability to be seen in person or not, or maybe being told they can't be seen in person, they must have virtual visits. What organizations need to commit to is a strategy that serves those patients, and that experience is at least commensurate, if not equal. So if you go to the next slide, there are some common tools, and I think when we start working with clients on these types of issues, there's often concern that we're starting from scratch. Oftentimes in organizations that have been thinking about any kind of consumer-centric approach, there are often personas, meaning there's understood targets. There are journeys or journey maps. So these are some examples that we've done for clients. And actually those can be translated into actionable events using marketing automation technology. So this is, for example, on the lower right, this is a journey in Salesforce Marketing Cloud. So it tends to be that organizations know what that next step is, but they just need to enable it and make sure that we're successful helping patients get out of their own way and kind of stick with that journey. And so what this commitment looks like is taking this kind of thought leadership and really committing to a strategy that you can put down on paper and start to take action forward on, because without this, our concern is that these patients will start to self-direct themselves and get pulled in a bunch of other directions. That what we need to do is maintain really clear communication, but also make sure that we're progressing patients back through the care journey and back to the health that they're looking to get to. So that's the fourth commitment. I'll pass it back to Tom for our fifth commitment.
Thanks, Paul. So the fifth commitment is that health systems need to proactively engage their target patients to match their care needs with their appropriate and available sites of care. We can go to the next slide. And so this is really a fundamental reorientation, right? So healthcare access has always been about reacting to patient demand, right? And all of our clients that we work with, it's always a struggle with making sure you got sufficient supply and you make sure you're as responsive as possible. But the nature of being in a reactive demand model is you're always going to be behind the eight ball. And it's only going to get worse because we can all see the foreseeable increases in patient demand coming with aging populations, much higher utilization per person, and the overarching retirement of physicians not being backfilled sufficiently by the replacements, therefore just creating a greater chasm, frankly, between the available supply and the mounting demand. So there's a care model option or element here, certainly, but what's even more central to it is getting out of this reactive model of care delivery. A, it's bad for care when we leave everything to the patients, and B, it's impossible to manage effectively. It's just unwieldy and is always, like I said, trying to respond and react with resources that are not really structured to be versatile and responsive. And so being able to predict, the more we can predict, the more we can say this is the care that's coming, the less we'll have to react to care when people say, oh, I'm overdue for my appointment, I need to get that scheduled. And so it's going to require, as I said, a different care model, and it's going to require an explicit organizational cultural shift of the caregiving philosophy to begin to think about how we interact, when we interact, and what we say when we do it. And so organizations are going to have to commit to capabilities to begin to proactively engage with patients in a thoughtful, but also in an economically sustainable way. It's clear that this is a gateway to population health, which I think almost everyone in healthcare who goes into this industry is committed to having an impact on. But it's also a way that works in a fee-for-service world by providing better care more timely, which has a positive revenue implication and maybe averts some more costly acute care interactions over the long term. Again, we can cover through better access and better patient throughput. Next slide. And so there are really 4 steps to being able to do this, and it builds off some of the things we talked about earlier. The first one is you need to have more options of care. If your only supply is an in-person visit with a physician, you're constraining your resource, and no matter what you do, anything you do that adds demand, it's just going to exacerbate the fact you don't have enough supply. So you need to expand your channels. You need to change the care model to give better leverage to your clinicians and your physicians to expand the care team to be able to create more entry points for patients. Second, you need to be able to track your care supply or your capacity across all modalities and in real time. So that means online availability. It doesn't mean every patient can schedule online, but the health system has to be able to see all of their clinical capacity for their physicians online. So fully appreciate the complexity of what that means to get all schedules online, to get them available, to be able to record them and manage them. But if you can't do that, you can't move to the next step, which is what Paul was talking about, which is how do you start tracking and doing something with those next steps? For every single patient, a well visit, for a patient being referred to another specialist, for a patient that a physician's going to want to do another well visit, primary care follow-up in a year, there is always a next step. And it's not just talking about it and saying to the patient, hey, your next step is come see me in a year. It's documenting it and tracking it in a system that we can then know and act on that, which really comes to the last point, which is once you have your supply, once you have an inflow understanding of your reactionary volume, you can start layering in your proactive outreach. And the more you do that proactive outreach, you'll start to see a subtle shift in the balance. More and more proactive will reduce the inflow of reactive. And over time, you'll start to shift your balance to be differential, proactive consumer outreach averting the constant scuttle of trying to manage the reactive side. Again, this is not something that can just be flipped on like that, but this orientation is essential to getting us out of the reactive world and ever getting on a path to being able to drive health outcomes and top health for the clinical next steps that our care teams are defining. Sam, back to you.
All right. Thanks, Tom. We are at our last commitment, the sixth commitment, which is to deploy patient triage and routing tools that extend across both virtual and physical sites of care to assign the patient on appropriate clinical tracks. Next slide. So what does that mean? What should we commit to? And really, it's committing to some sort of analytical platform or analytics. We've seen health systems begin to make investments in these digital networks and virtual care, consumerism, digital engagement, retail care. The clinical track or journey the patient is on is the same mindset that we need to approach our clinical care teams with. Through COVID, we took a team that was already burning out, our physicians, our nurses, and we burnt them out even more. So this impacts not only patient care, but also patient and clinical outcomes. And because a clinician that's burned out, they're not going to provide the best level of care. So we need analytical tools to know when, where, if they've been exposed or not. And we also need to know if they've been overworked or make them productive from their home if they're under quarantine. And it's not only for burnout, but also contact tracing, who has COVID, who doesn't. As I mentioned, quarantining and then replacement of these staff and getting new staff on board and onboarding them. So that workflow and business process in this post-COVID era are things that need to be looked at and prioritized. So this advances the initiatives of the quadruple aim and the changing regulatory ecosystems that involve having a digital journey. At the same time, we want to remember that we still need to be empathetic every step of the journey. But just like Amazon, we want to know every step of the way, and we want to be informed by every step in the process, just like a consumer engagement experience. And so therefore, analytics are going to be necessary and required. Next slide. And so where we've really seen this happen more recently is at the University of Chicago. They have over 1,200 beds, 4 acute inpatient facilities. And with a strong analytics platform, they were able to provide up-to-the-minute statuses of confirmed and potential COVID-19 patients in the hospital, along with testing updates. So the operational and infection leadership was able to use this to have a real-time pulse on the demand of COVID-19 and how it placed a major stress on the health system in these 4 different facilities. And they were able to track trends with ventilators sorted by COVID-19 status. And this helped the ICU leadership monitor and plan all their resourcing. So this is complex data that's coming together onto a single utilized platform. And that platform's Tableau, and it was able to break out patient admissions and discharges per day, taking even a step further to look at the average length of stays, the patient percentages required by the ICU, and then the deaths per week. So the care teams and the administrators could filter out the data by various operational and demographic parameters to identify potential variation in all of the variety of patient outcomes. And again, we need to be looking at this dynamic environment with all the right tools. So this is just a couple examples of the complexity a health system is dealing with on a minute-by-minute basis. And then it's also bringing back the point of the patient journey and how it's not only for the patient, but it's also for the clinicians and the medical staff and how they have to be informed every step of the way. So thinking, again, of that mindset of the consumer experience. So finally, this is about managing populations at large. And it's not about having that old model that we've been talking about of transactional care. This is the new model. It's a journey that interacts with the patients along the way, and it keeps them healthier longer and engaged throughout the health system. So I want to thank everyone, and I'm going to hand it off to Paul to talk about the next steps. Next slide.
Thanks, Sam. So as we mentioned, we're hoping to try to start conversations, not finish them, with this presentation. Part of the ways that we've been getting into these conversations is that we've actually been blogging about it. So if you follow myself or Tom or Sam on LinkedIn, you would see we've kind of published the first 5 commitments. So if you wanted to go a little bit deeper, I would encourage you to go out and take a look at any of them and kind of read through them. The 6th one will be coming out this week, so Dr. Sam will be publishing that out, so you got to preview it here first. But I think what we're hoping for, as I mentioned, is to try to start some conversations. If you go to the next slide, as a way to do that, our goal is really to help catalyze the current adaptive plans into longer-term strategic advantages. I mean, part of the reason we put this together is we see clients really struggling to just figure out something that'll work next week. And I think as we've seen some themes emerge over what is really going to serve healthcare organizations over the long haul, it's frankly not that much more work to adapt in the short term than to make some of these longer term strategic advantages. In fact, the reason that we're talking at this level and trying to engage in a conversation around thought leadership in terms of what's working in the market, and then also by framing these decisions as commitment, I think it's our hope that we can help you explore your organizational and strategic alignment first. That, as we mentioned before, it's more important that organizations are able to commit to an ideal in the future or commit to a way to make decisions, because we know that any individual decision is going to be greatly varied from organization to organization. But if you agree these commitments are important, we want to assess how you're taking actions. We actually want to know if you see in your organization that, yes, my organization is committed to a few of these, because we're actually looking for success stories. As I mentioned at the top, we really do want to be kind of good news and bright spots in the healthcare industry. And so this is really a way that the 3 of us could think about how to share out what's working. So we're looking for the success stories as we begin to kind of move this blog and multimedia format into a white paper to share. So we would love your feedback. We're actually going to host some office hours next week. If you want, we'll kind of provide a follow-up email of how you can sign up or drop in to engage us in further conversation if that's of interest. And obviously right now we'd love to get a little bit of time to do some Q&A with you. So we left the kind of last 10 minutes explicitly for that, with the hopes that, again, we could start some of these conversations, not finish them, and with the hopes that, if you have things that that are working, we love to hear them as well. So with that, I'll kind of pause here and let Sam or Asma help us out with whatever questions might already be there, but I'll just thank you once again for the 3 of us. This was an idea that we had, stuck in our homes like everyone else back in like April or May. So I'm really pleased that you were able to join us and really hope that you can help us refine our thinking and our research.
Yeah, thanks, Paul. I also want to thank Paul and Tom and teams, as well as the Salesforce team, for helping out put this together. But we're now going to open it up to any questions.
I have one for Tom. I'll kind of get the ball rolling because I'd seen that virtual visit data before, but it's certainly, you keep updating it. What do you expect the right percentage of virtual visits to in real life visits will be, given that it went from 1 to 50-something% and now is hovering around 20%. Do you have any ideas of what that's going to be through the rest of the year?
Well, for the rest of the year, I would say we'll probably see it hovering and start to back up. We've looked at this. We went through the Kythera data and went by CPT and basically looked at what happened pre-COVID on overall volumes, what kinds of cases were able to be virtualized during COVID. And then if you model that out, and again, it varies enormously by specialty. But it's interesting that if you take what was able to be done virtually during that period, it's going to be somewhere in like the 30 to 35% of all care in the pre-COVID number that could be virtualized. And that's not changing elements of the care model. If you think about a different care model, you would use virtual differently. It's lower activation. That is purely just looking at, based on a CPT mapping, what's substitutable. And there's a lot of assumptions in that, but directionally it would suggest that about even now, as we see online care or physical care coming back online, there's an opportunity for about twice as much virtual care to be happening as a proportion to physical care.
Wow, thank you.
All right, with that, we are going to conclude our session today. As always, if you want to find out more about any of the capabilities showcased today, please reach out to your AE or visit worktalk.com. Thanks again, everyone, for joining, and enjoy the rest of your afternoon.